Due to the above problems, transcranial endoscopy microsurgery TEM was developed in 1984 by Professor Booth. Compared to conventional transcranial incisions, TEM is capable of providing high quality local incision. It has been demonstrated that in careful selective T1 rectal cancers, TEM provides low local recurrence rate and improve survival and safe and effective with similar morbidity and mortality. However, while TEM provides these superior outcomes, it has not become universally adapted by colorectal surgeon due to its steep learning curve and because of highly specialized instrumentations. Then, in 2009, transcranial minimal invasive surgery TAMIS was developed. It offers alternative to TEM, and TAMIS can be accomplished by a variety of disposable multi-channel ports. Here you can see pictures. Combined with user-ordinary laparoscope instruments. There are differences between these two platforms, TEM and TAMIS. Okay, here is TEO by Carstairs. The diameter of the TEO and is 40 millimeter, and the length of the shaft is 7.5, 15, and 20 centimeters. And the right picture says the TEO is set. And then there is various of disposable TAMIS port. Length range varies from 37 to 44 millimeter, and diameter varies from 34 to 40 millimeter. And when talking about the price, the convenience port, for example, is approximately $650 per application. Setup time is listed in TAMIS, as you can see, just put a TAMIS port in any connect after lubricating it instead of setting up like this. So the setup time is, especially when you try to make a specimen extraction and reset. But one more advantage of TAMIS over TEM lies in the access design. Made from thermoplastic elastomers, the steel pole is pliable and allow for a confined fit with the anal canal. Furthermore, the ability to introduce a conventional laparoscope instrument through the 12 millimeter ports is feature exclusive to TAMIS and cannot be accomplished by TEM. So TAMIS, when compared TAMIS to TEM, low cost, minimal setup time, and more pliable is the advantages. Here I'm going to describe the TAMIS procedure in our hospital. First and most important, patient selections. Patient with benign adenomas or neuroendocrine tumors less than 2 centimeters in diameter and will differentiate T1 invasive adenocarcinoma with evidence of liver vascular invasion. And for patients with severe comorbid condition for which curative intent standard acromegalular resections or intra-inducted TAMIS local incision was performed as an alternative. For such patients with severe comorbidity, TAMIS was performed on more advanced regions, including clinical stage T2 and negative or T3 negative regions, as well as histological unfavorable T1 negative regions. Additionally, patients with clinical complete pathological response to neoadjuvant treatment up endoscopic evaluation were also given options of TAMIS local incision to confirm the neural sterilization, means YPT0. The patient received rectal enema in the morning on operation day. A second generation cephalosporin, or if the patient is allergic to cephalosporin, ertapenem instead, is given priorly 30 minutes before operation. All patients were administered general endotracheal anesthesia with pharmacological paralysis. Patient positioning in operating room will depend on the anatomic the location of the tumor. For posterior lesions, patients were positioned dorsal-ectotomy, while anterior lesions require the patient to be positioned project knife. Standard laparoscopy instruments were used to perform incision. Numerator was established by using carbon dioxide separation with an initial pressure set up at 15 mmHg pressure. Talking about excision, floor thickness excision with 1 cm minimum negative margin for all malignant lesions. Process thickness of submucosal excision will perform as a discussion of the operating surgeon for a patient with morphologically benign appearing adenomas. All defects were closed completely with absorbable material. Oral antibiotics with anaerobic and gram-negative coverage for a period of 7 days. Here is a video of a partial thickness of submucosal excision. We usually mark the margin, then we can know when we do a submucosal excision or partial thickness excision, the range. Then we do the submucosal excision. And you can see the muscular is beneath. The difference between the TAM and the TAMIS is that when we do a dissection, the TAM is fixed, and you cannot put the laparoscopic lens for room in or room out. But if the TAMIS, you can rotate the camera or care lens, and you can room in and room out to see more accurate what your eyes. It says. And here is a video for fullness excision. As we previously told that we will make a 1 cm gross negative margin. Then we do a excision, and you can see a parallel bed, and make sure that you do a full thickness excision. And all the defect is closed, and we use a VLAC, the absorbable material. It sensitizes when we don't need to knock it. Okay, because of the time, so. Here is our experience. 34 patients underwent TAMIS between 2013 April and 2014 July. It consists of 34 patients, consists of 18 men and 16 women, with the average age of 60 years. And the distal from the anaverge to the most distal part of the tumor is 5.6 centimeters. Of the 34 patients, 11 patients had benign lesions, 90 patients had malignant lesions, and 4 patients had neuroendocrine tumors. Of the 90 patients with malignant pathology, 5 had pathological T1 lesions, and 3 had T2 lesions, and 11 patients had neoadjuvant treatment, while 4 of them have complete pathological response. The average post-op hospital stay was 2.5 days, ranged from 1 to 9 days. The average total operating time was 136 minutes. All patients were removed with grossly and microscopic margin. There was no mortality after TAMIS for excision. Early complications to 2 patients all receive the neoadjuvant treatment with the reasons and absence. While there are many applications for tummies beyond local incision, tummies DME with a shorter operating shaft, tummies is probably better suited for transnasal TME than TEM because a shorter shaft allows the dissection to begin in a very distal rectum and significant wider working angles can be achieved. Repair of rectal urethral fistula is also reported, and you can use the extraction of sigmoid foreign body, and then we have done the repair of low rectal anastomotic leakage. Here's a video. This is a 51-year-old male patient with a middle rectal cancer and a TME. Anastomotic leakage with pelvic abscess after TME is noted. So you can see the statement here, and we debride and make sure there's viable and soft, healthy tissue. Then we try to aspire the pelvic abscess. You can see the drainage as a previous TME left. It's a final when we suture a defect. Okay, back to our previous questions. As you all know, and how should it be treated? You may put the tummies on one of your list of choice. Thank you very much.
Thank you, Dr. Chai, last speak. And we move on to last speaker, Dr. Zhang Shenji. He was great from received a training from China Medical University Hospital. Now he is attending staff in colorectal surgery since 2010, China Medical University Hospital. He will give us the speak for common energy sources, monopolar and bipolar and advanced bipolar. Please, Dr.
Thank you, Mr. Moderator. Today I will talk about the common energy source. It's related to the bipolar, monopolar, and its complications. Okay. For current surgery, surgeon cannot lift electrosurgical instrument, and it became the most trustable partner for our surgeon. And the desirable energy instrument should follow this item, including the security, safety, efficiency, convenience, and the less interference. In laparoscopic surgery, we must do tissue dissection and vascular coagulation. Monopolar and ultrasound was used for tissue dissection, and bipolar and ultrasonic coagulation was used for coagulation. Irreversible tissue damage occurred at 40 degrees, and the tissue dissection started. Coagulation occurred since the 80 degree, and that results collagen denature and then desiccation. After 200 degrees, tissue degradation and the tissue will be cut. Okay. Monopolar need active electrode for working, vital body for current circuit, and ground electropod for receive the current. In laparoscopy, we use the smaller tip for dissection because it needs only 12 to 15 watts to achieve the desired effect. Although cut wave is continued, its voltage is low. So the tissue damage cutting mode results lower injury than combination. According to Ohm's law, electric current always pass the latest resistance path. If the target became carbonization, like here, the current will go the other side and may result in burn injury. Alternative, the injury with monopolar may occur as the target tissue increase resistance. Direct thermal extension most occur in laparoscopic cholecystectomy and most cause duodenal injury. Therefore, when we are doing the laparoscopic enterolysis, cut mode or a combination with tissue tension was suggested. The following will introduce the monopolar related complication. Direct coupling injury was the most accident. Most common bile duct delay injury in laparoscopic cholecystectomy is associated with this kind of injury. And the monopolar cannot used at the stable line directly because it will result metal to metal arcing, and then the anastomosis site will damage and the delayed anastomosis leakage will occur. Up to 20% reusable laparoscopic instrument may result in insulation failure due to long-term handling and cleaning. After repeat wash, instrument break may occur and result current leak and bowel injury, especially at the zone 2 of the instrument. So we suggest a single use of the instrument and care for examination of the zone 2 of the instrument is needed. And capacitive coupling occurred because the electromagnetic field around the active electrode induce a current in nearby conduction. And this is the second conduction. After we use the monopolar, the conduction will injury to the surrounding tissue. So we should suggest we can reduce using the metal trocar, and we don't need to bend our wire like this. It will also result in capacitive coupling injury. If we did a single port surgery, monopolar using should pay more attention. In single port surgery, the instrument had longer zone 2 length, and this instrument was too close together. That may increase the risk of capacitive coupling and direct coupling by the insulation failure. Then we'll talk about the ultrasonic dissection. Ultrasonic dissection can convert electric surgery to blend vibration. This vibration frequency can reach 23 to 55 kilohertz that generate heat. This shear, the ultrasonic shear, is a composed device including cutting and coagulation. And how to control the ultrasonic cut or ultrasonic coagulation is according to the following factors, including the tissue tension, power setting, blood pressure, and the percentage of water in tissue. If we want to use the ultrasonic cut, we must increase the compression and increase the tissue tension and set the higher power. Residual heat is the most important risk of the ultrasonic. In this video, we can see the blade was retained a killer temperature. You see, 3, 4. In the paper, it also writes at least 45 seconds. If the ureter or small bowel contact is immediate before adequate cooling period, a full thickening injury may occur. Okay. And the ultrasonic device vibration will easily produce the steam convection. And this steam convection will affect our working. So we suggest symmetric suction during lavascular ultrasonic using is needed. Okay, when we are doing the tissue dissection, how should we choose this device? In the monopolar energy, yeah, it's quick, and we can wear. It has a well anatomic identification, but its hemostasis is worse. So we suggest when we are doing the anatomic plane dissection, we can use the monopolar. Contrast to the ultrasonic device, although it has good hemostasis, but it may destroy the anatomic plane. So when we are doing the vascular-rich soft tissue dissection, I suggest we can use the ultrasonic device. Okay, this is our partner and our guest. Okay, many methods can reach hemostasis. Suture is the oldest and the most useful method. Energy causes vessel denaturation, desiccation, and then sealing. Advanced bipolar can ligate vessel at 7 milliliter, and ultrasonic only 5 milliliter, and the bipolar only 2 milliliter. Bipolar has local electric return. It results higher current concentration but low voltage. However, its vessel sealing is not secure enough. And sometimes current balloon around electrode occurred like this. And it will cause incident injury to nearby organ. This is the incident injury. So advanced bipolar was created, and it increased the tissue compression power. And this compression reduced the water content and make the desiccation homogeneously. It also improved the generator to integrate adaptive control that can sense the impedance and then respond immediately. Therefore, the advanced bipolar can fuse and cut vessel up to 7 milliliter. And three mechanisms to create the compression was noted. The ligature used the spring and the pin method, and the Ancel used the controlled gap. The jaw will pull together by the control gap and result large grasp pressure. And the Thunderbit used the Weaver jaw mechanism. The following is the different advanced bipolar device used in my clinical practice. And the ligature is the oldest advanced bipolar, and it results the most reliable vessel sealing. In a paper from the 2011, the effective vessel sealing rate was 99.8% in 802 patients. And its variety of the ligature was many products. We also use ligature to do the hemorrhoidectomy. Use this. And but we must pay more attention. This is the one side of the ligature. The ligature tip has no sealing function. If we use this kind of ligature, we must pay more attention. Ancel, due to the different technology design, the electric current curve pass inner the jaw, so it causes the minimal thermal spread, like this. By the paper in 2007, we found Ancel has highest bursting pressure and less thermal damage compared to harmonic and ligature. In the up-to-date 2014, Ancel only records 1.1 millimeter thermal spread. Sunbeam. Sunbeam was the first and the world's only integrated surgical device, including bipolar and ultrasonic. It can rapid tissue cutting with simultaneously coagulation. This is the ultrasonic function. We can see it's quick and its hemostasis is good. And this is the coagulation function. It can seal the vessel very, very good, but it takes longer time. Often it takes more than 10 seconds when we are doing the vascular coagulation. Yes. Good instrument can be equal to safe operation. In this condition, we use the good instrument. When we do the first vessel sealing, it's good. When we do the next one, it's bleeding. It's bleeding. Even though we crush it again and use this good instrument, it's still bleeding. So we count the bleeder site by another process. And then finally we use suture to resolve this problem. So, okay, the preferred vessel sealing should be the following. Vessel relax and leave away the vascular particle like the video we show. And the adequate division of the vessel. We cannot ligate the vessel like this one. This has much mass. And perpendicular firing of the energy device across the blood vessel is also important, or you may result bleeding. Okay, I hope every surgeon and everyone can have the same operation. Thank you for your attention.
Thank you for the speaker. I think time limited for some discussion is allowed. Is any question from the audience to the speakers?
I would like to ask Professor Abraham about the IgG technology. What is the proper time to use this technology? Just after the transaction and before anastomotic, or at the initial period of the operation to identify the vessel? What's your opinion?
Please, the Dr. Wexner and please take
Very specifically, the example that I showed was after splenic flexure mobilization was performed, and we were ready to perform the anastomosis just before the anastomosis. The use of the dye, the injection of the dye, can be it's valuable. There's a lot of opinions, a lot of experimental work out there. For instance, for the vial, we know that it goes into the vial within 20 minutes. But if you want it into a solid organ, for instance, you have to do it 24 hours before. For instance, when you're doing liver surgery. For the colon, it varies. I don't know what it was in the Bigelow study. In our study, we do it about 15 to 20 minutes before the operation starts.
The indocyanic green that we're using in the pillar study that we published in Surgeons a few minutes ago, you give it's instantaneous. It just goes through a couple of quick circulatory passes. And in fact, if you don't have your camera ready to go, and you give it, and then set up your camera, usually it's done. So we watch it out that quickly.
Exactly. But you can do a booster. We do a booster also. So it is. Yeah. It's It's facilitated, as a matter of fact.
The way we were doing it in the trial was at 2 points. One prior to transecting the bowel for anastomosis to confirm the point that we wanted. And then the second point was after anastomosis, transanally, looking at the mucosa proximal and distal. But you can add a third point, which is just before or after you create the anastomosis suturocoileally. So you can do it at that time as well. It's the same camera, laparoscopically or open, or it's a special custom-made proctoscope either way.
Any, please, at the end.
One question for Professor Brown.
Sorry, one question for Professor Brown. According to your study, how soon you apply the radio frequency to the animal after the fecal incontinence was created? Because most of the patients with fecal incontinence, the procedure may be insidious, and they may wait for months or even years, then they come to see a doctor. So how should you apply the radio frequency?
It was very soon after. I know that ideally we could have had different times, but it was just, the model was just for the purpose of looking at the histological features, so it was that one time.
Any, please, Dr. Chen.
Well, I have a question for Stephen about bowel preparation. I think both of you came from different countries. In the United States, bowel preparation is mandatory for surgery, at least majority of the surgeons. But in Europe, I think many of the surgeons are not doing bowel preparation for colorectal surgery. And what's you guys' point of view based on, are you going to prep the patient preoperatively or no prep for colon surgery?
I don't think it's mandatory any longer in the U.S. I think it's, if people want to do it, they do. I find laparoscopically it's easier to handle the bowel if it's empty, and I tend to perform intraoperative endoscopy on pretty much everyone. Either I'm looking for a polyp, or I'm looking for an ink mark, or it's a syphilitic and I want to see the mucosa. And in every case, I look at the anastomosis. As you know, before we transect distally, I look at the level, and then after I put the linear staple line, I air test that. And then I look at the anastomosis. We do routine intraoperative endoscopies. I think because the amount of times I use endoscopy, it makes sense to do it, but I'm not doing it to prevent infection or any other reason. I'm doing it to facilitate endoscopy.
Yeah, I would agree with that, as was stated in the talk. The only remark I'd like to add is that in the SLIM study, the last meta-analysis that was published in British Journal of Surgery, as well as the other one, as a matter of fact, the Cochrane, they did not include, I don't want to be too nationalistic, they did not include 2 French studies that were performed